Hi guys, good afternoon. Thanks for joining us. We'll talk this week for about 45 minutes or so on masses in the heart. And this is commonly brought up in exams, and obviously I think commonly we see it in critically ill patients. And I guess let's just talk a little bit about what the most common causes of cardiac masses that we're going to see. So why don't we start, Lewis? First of all, let's just hit me. Give me sort of the list of the commonest things. If we see a mass in the heart, what are the commonest things you think we're going to be dealing with?
Normal variants probably most common.
Okay.
And
that as well.
of them, a lot of them are in the right atrium.
Yeah. Okay. So normal variant, beautiful.
So leaving right atrial things aside, probably in critical care, undiagnosed previous masses.
Mass that we'd see.
So the commonest cardiac masses are myxomata and other tumours, and then thrombus would probably be much more common in critical care than outside of it, I guess.
Yeah, nice.
And the sort of tumours that we'd see would be metastatic, I suppose equally with cardiac tumours. I haven't actually looked that up. Metastatic being renal.
Yeah, cool.
And cardiac tumours, cardiac sarcomata.
Fantastic. So let's just pull it back to first principles. If you're getting this in the exam question, we're going to say that the cardiac masses, as you said, they're probably more common in the critically ill than not. And that's going to be for a couple of reasons. The first, as you've just said, is that thrombus are probably more likely in the critically ill because you're hypercoagulable from everything from sepsis to bad cardiac flow, absolutely. But I think what's probably more common, you talked about the most common thing being normal variants, and I'll agree that that's probably most common. I'd argue that probably even more common than that is artifacts. So the most common thing, the most common masses that seem to be brought up in the critically ill is because they're hard to image are artifacts. And so we're going to have to be able to figure out whether we're dealing with a real structure or not. And in the exam, if they talk about you say the question is, a registrar comes along and says they've seen a cardiac mass, there's going to be the easy mark is going to be saying, we've got to make sure it's not an artifact. And the simple way we try and figure out if it's not an artifact or not is, can you see it in another view or not? Can you see it if you reduce the depth? Can you see it if you go off axis? Can you see it if does that 2D image, that mass, if we put color Doppler box over the top, does the color go over the top of it? That would suggest that it's an artifact. So artifacts, first of all, are a possible mass, and we need to exclude those first. The normal variants that we'd see, you talk about in the right atrium, we've got Chiari malformations, you've got the Eustachian ridge. Those are the most common ones that we'd see. After that, I'd say iatrogenic, sticking in leads. So the pacemaker wire, the PICC line, the central line that's maybe, or the vas cath that's put in a generous amount. Some of the units that I worked in, they said that they used echo to show that a vas cath was in the right atrium because that's when they thought that it worked the best. Not unreasonable. I think the risk is you don't want to go anywhere near the tricuspid valve. You've got to be back from that. But some people would say that get best flows when you've got a vas cath that's sitting in the right atrium. So I think after we've said about artifacts, normal variants in the right atrium, don't forget we got Lamble's excrescence, I'd say degenerative disease on aortic and mitral valves. And then we talk about the leads that we're going to have in the right heart chambers. I reckon after that comes the stuff that everyone's ready to churn out. That's the stuff that we know about. And I remember that one of the guys that taught me about echo said that if you see a mass in the heart, it's either a thrombus. If it's not that, it could be infective endocarditis if you've got a good clinical story. And after that, it's probably thrombus. And if it's not either of those three, it's still probably thrombus because the rest of them are super uncommon. And things like tumors, cardiac tumors, we all want to talk about it. But again, they're not super common. We don't see them very often. Metastatic disease, much, much more common than primary disease in the order of, I think it's like 20 or 30 times more common. And the tumours that the most commonly ones, exactly as you mentioned there, Lewis, are the hydronephromas, the ones that creep up into the right atrium and they'd be the most common, as well as metastatic disease like lymphoma. Those would be more the common. And the ones that are more likely to metastasize to the heart are also the ones where you've got double things, particularly like breasts, lungs, kidneys. Those are more likely to metastasize to the heart. The final thing we'd mention on that list would be the primary cardiac tumors. And like you said, it's the myxomas, most commonly seen in the left atrium, things on a ball with a stalk coming off it. And you can see them in other places, but left atrium is most common. Sometimes you see it in the right atrium, and you can see them elsewhere, but it gets less and less common. The newest data that comes out, we say that the most common primary cancer is the myxoma. And I'll tell you what, I'll put a little sheet into the Dropbox link talking about cardiac masses, because the one that's just usurped it in the last couple of years, they talk about the papillary fibroelastomas. Those are now probably the most common primary cardiac tumor. It's benign, again, like a myxoma, and it sits like a little pom-pom that sits on it sits on particularly the aortic valve, just at the tops of the leaflets. And if we have time, I'll go and try and dig one out and show it to you. So I guess if you're answering a question in a DDU, think broad, think about those differentials. Don't forget the easy marks I'm mentioning: artifact, normal variants, like the Lambert's excrescence, like the Chiari networks and the eustachian ridge. Talk about the iatrogenic material in there. So those are all just easy money for jam that you've got to mention as potential causes of cardiac masses in the critically ill. And then you can go on to talk about thrombus and infective endocarditis if the story's good. Thrombus is always going to be super common, particularly in the critically ill with a hypercoagulable state. And then you can talk about the tumors. And metastatic being more common than primary. Myxomas, papillary fibrolastomas being the most common primary tumor. And the last thing it talks about, if they talk about your approach to seeing a mass, don't forget about the next easy money, which is talking about needing transesophageal echo. The sensitivity and specificity are much better with TOE compared to transthoracic. I guess that's the sort of DDU teaching in summary in about 5 minutes flat for how we do that. Does that make sense? Does that sound okay? Anything you wanted to add to that, Benny or Michelle? All right. Well, how about we do a couple of cases and we talk through a few of the more common ones that we'd see in the ICU in that case, all right? Nothing that anyone wanted to say about any of that? Good?
Okay, guys, you ready to go? Let's have a look at this. We've got a patient who is in 65 or so, 60 years old, who's got strep viridans in her blood culture. She's got a history of a bioprosthetic aortic valve. So are you guys doing a bit of TOE? Are you okay with me talking TOE? Lewis, you do a bit?
I've done very, very little, yeah.
How about Ravi? Are you doing a bit of TOE? Do you want me to talk through this one? Or maybe, how about I give a bit of a, do you want me to do a little bit of chatting with this one then if you don't do a lot of TOE?
Yes, please.
No problem at all. Okay, well, just talk a little bit about what do you think we're looking at? What's this structure here at the top? So on transesophageal echo.
So is this the would this almost be deep transgastric?
Fantastic. It's often the most common one that we start off with in an echo. So we go down deep into the stomach and we look back up at the heart. So we don't always have a perfect view from the apex, but it's about as close as we get. And the reason why I like this view is because we get the best view through the aortic valve. All right, so that's what we see here. It's about as close to an apical 5-chamber view as we can get with TOE. One of the problems that we have with TOE is that you don't get beautiful Doppler alignment. And so we talked a little bit about prosthetic valves, I think it was last week. And what we talked about was looking at artifacts. And here with this valve, you can see that we've got some pretty significant artifacts with this dropout behind the valve, but we still can see a valve structure in there. And you're probably picking up that there's this heterogeneous, irregular mass with independent motion that's sitting there on a valve leaflet. So what can we say? Are we dealing with a metallic or are we dealing with a bioprosthetic valve?
I guess bioprosthetic.
Fantastic.
It's complex motion.
Yeah, beautiful. So if we can see a valve, we know that we're dealing with a bioprosthetic valve. And if you've got this artifact, particularly around sort of the outside or the skirt of the of the artificial valve, that tells you that we've got a bioprosthetic valve. If it's metallic, you can't bloody see anything, and you just got this dropout behind it, and these really sort of stark sort of reverberation artifacts almost behind it. And what we're looking for masses, if we've got a good story of someone who's in septic shock with strep viridans, and we've got, you hear a murmur, or you've got a history of a bioprosthetic valve, you've got to be doing toes because of the increased specificity and sensitivity that we discussed, and we go looking for masses. So Ravi, guys, talk to us out there. How do you pick up whether something's infective endocarditis? What are the typical features of infective endocarditis on echo?
So it will be echogenic material, homogeneous, freely moving.
Yep.
There's an oscillating mass in the pathway of a regurgitant jet.
Fantastic. We often talk about they've got independent motion. So it's actually often a heterogeneous mass. Sorry, I couldn't even if it's homogeneous or heterogeneous. It's often heterogeneous mass that we're seeing, irregular in shape with independent motion. As we're seeing here with someone with strep viridans, this is a bloody great mass that's sitting there on the bioprosthetic aortic valve. Nice. And talk to me a little bit more about that regurgitation jet. What were you saying about that?
So in the pathway of a regurgitant jet.
Yeah, okay, in the pathway of regurgitant jet. And we often talk about it being on the area that's where the low flow is starting to build up. So particularly on the sort of the atrial side of the mitral valve, or on the ventricular side of the aortic valve. And that's not a hard and fast rule. It's sort of often on the sort of downstream portion. And with the regurgitation that we're seeing, can you tell me a little bit more about what you'd expect from the color flow that you'd see with someone who's got a nasty mass?
So there is a lot of turbulence that we can see.
Very good.
Mass.
Very good. So if you've got someone who's got infective endocarditis, you often see quite, I describe it as chaotic motion. So if you have the variance that's, if I put it on with this, can you see as I can turn off and on the variance? Can you guys see me doing that?
Yeah.
Put on the variance, that means that when you're starting to get chaotic motion where there's a lot of variation in the Doppler profile that comes through, it shines through as green. And it's a little tricky when you're dealing with a bioprosthetic valve because we've got quite a lot of artifact around, but maybe I could just persuade you that's so one of the things we can look at. You're looking for very chaotic motion, and we're also looking for horribly eccentric looking jets. And I'll show you maybe some other examples in a minute of that. So even if you're dealing with very small infective endocarditis lesions, normally on sort of native valves we're dealing with, if you're starting to see horrible eccentric looking chaotic jets, and you've got someone who's got positive blood cultures, that's got to raise your suspicion that we're dealing with someone with an infective endocarditis, and we've got to go hunting. Because of course we've only got a 2-dimensional imaging tool, 3-dimensional structure, and we've got to go hunting for infective endocarditis if someone's got positive blood cultures, the Duke's criteria that is suggestive for us to go and find it. If you see that eccentric jet or chaotic motion, go hunting for infective endocarditis. So I guess what we can see here in our sort of deep gastric look at our aortic valve is this heterogeneous, irregular echogenic mass sitting there on the ventricular side of the bioprosthetic aortic valve. And it ain't small, is it? When we zoom in on it, we can see if we pause it, it's at least probably a centimeter in size. I'll just try and measure it up. I'll be measuring something along the lines of that. So we've got someone who's got 9 by 8 millimeter vegetation that's sitting there on the aortic valve, and it's meeting all our criteria of something on an area. If you thought that someone was going to get it, if they had a bioprosthetic valve, they'd probably get it on the valve. If you've got strep viridans, which is an organism that's highly sensitive to sticking on artificial products and causing infective endocarditis, you would not be calling this thrombus. In that clinical setting, you'd be calling it infective endocarditis. So the next thing that we've got with toe is we can, in a deep gastric view, you can see this Doppler alignment that I've got that's not perfect, but it's the best we're going to get with toe, more or less. And we can see here that we've got continuous wave Doppler through that aortic valve. And if I trace this out, here we've got a Vmax of 2.6, so it's over the 2.5 that we get worried about, suggesting that we're sort of getting into maybe sort of the more moderate territory there. And we've only got a mean gradient of 15, but one might argue that we're not quite on axis, so we're probably going to underestimate it as we go. Let's ask him, Ravi, I've just measured this out and I've got some values. Tell me, can you critically analyze this Doppler profile for me? How could it be better?
So where is the, I can't actually see the alignment.
Nice. So really nice. First of all, you want to see that you've got a good Doppler alignment, because remember the echo machine, much like your wife, assumes you're perfect. And so you have got to be exactly down the gun barrel of the flow of that valve. And I'm sorry you can't see it, but can I persuade you that I'm probably at least 20 degrees at least off?
Yes.
So I'm going to underestimate the flows there. Beautiful. So first thing with the Doppler profile is, are you in alignment with it? Nice. And then can you talk to me about optimizing the Doppler trace? Do you reckon I've done an okay job with that here?
So the baseline is right up to the top. So you get maximum.
Yep, you want the baseline up at the top. Yep.
And the velocities, the scale has been adjusted so that the entire wave profile captures the entire screen.
Very nice. Excellent. And how many cardiac cycles should we have in a screen?
So 5.
Yeah, and I think in atrial fibrillation, we often say have 5, and sinus rhythm 3. So it actually wasn't me that did this. I think it was Vishal that did this case. So we can't bag him out too much. I think he did a pretty good job, right? And we could argue that you've got to make sure you don't overgain things, so you don't make it look like that. We want to check the modal velocity, so I often turn down the gain until it looks like we're capturing the majority of the profile. And then the last thing to talk about is how you do the tracing. Make sure that you ignore the fuzz or ignore the fluff, and you're just looking at capturing that where the majority of the blood flow are. My little tip and trick for trying to trace it accurately is don't look, you see, I'll try and do it on this one maybe. If I'm tracing this profile here, once I click and start doing the tracing, it's always much easier to do it on a computer than doing it on the echo machine. So I try and do it post-processing if I can. And then the next thing to suggest is don't look at the cursor. Look about 3 centimeters distal to the cursor. So you move the cursor where your eye is moving. All right. I'm sorry, I'm not doing a nut job. I haven't got my coffee. But don't look at the cursor. Look where you want the cursor to go, and that helps you trace accurately. It's like when you're driving a car. You don't look straight at the head of the bonnet. You look at the edge of the curve where you're turning into, or when you're surfing, you do the same thing. So always look ahead of where you're trying to go to. Don't look exactly where you're at. And I didn't demonstrate that very well on the image, but I think you get the idea. All right, let's try and find the next one.
Sam, just a question on the color Doppler. So since we are suspecting it's a bioprosthetic valve with infective endocarditis, we should also look closely for other complications of infective endocarditis. Like
fantastic. Taking the money out of my mouth. I don't think that's the expression at all, but you know what I mean. Absolutely. So I'll tell you, we brought that up. Let's just jump straight to the money. Okay. So what do you think of? So we found a lesion on the aortic valve. So the next thing to say, particularly in the exam, and particularly I think more relevant clinically, is if we see a lesion on one valve, particularly with a highly virulent bacteria, what do you think the chances are that we've got it on another valve?
Highly likely.
30%?
Yeah, it's about 30%, they say in some of the literature I've read. So if you see it on one valve, valve, you've got a 30% chance it's on another valve. So you've got to go hunting for it. And it's more likely, if it's on the aortic valve, it's more likely to be on the mitral valve than the tricuspid valve, obviously. If you're on the tricuspid valve, it can be bloody anywhere. So you just got to make sure we go and check out other valves. Okay, so Ravi, so that's our first rule. If it's on one valve, you've got a 30% chance on another valve.
Yeah.
What else do we need to look for if you're saying it's on the aortic valve?
If there's any like complications like paravalvular leak or paravalvular abscess. Or,
nice. Yeah, and keep going. So we're doing the bioprosthetic valve. So we've got to make sure there's no leak, that there's no abscess. Yep. And give me the last one, the most serious one.
The dislodgement.
Nice. So the whole valve is not moving. So those are the big things you've got to put in your report. If you're doing this for a colleague, you've got to, the way I would start off by saying it is the valve is well seated, or the valve is dehisced, which is obviously terrible. The valve is well seated with signs of normal flow. And obviously in this one, you'd say that the valve is well seated, but there's a huge mass that's 8 by 9 millimeters at least in size, which is a heterogeneous echogenic mass with independent motion on the ventricular side of the aortic valve. I think I can't see any horrific, looking at this view here, I can't see any horrific paravalvular leak, but I do have raised gradients on Doppler. I think it helps if you know the size of the valve and the type of the valve so you can estimate what normal are. But I'd suggest with velocities getting up to the 2.6 and the mean gradient being up around the 15, we got to start looking at trying to estimate whether we think there's some form of stenosis going on. How can you start telling, you talked about an abscess. How might I be able to figure out if there's an abscess or not here?
Either looking at the anatomy, like whether it's a smooth anatomy around the annulus.
Yep.
Junction of the valve, bioprosthetic valve with the root.
Yeah.
Is there a more echogenic material or irregular or different
okay. And again, we're talking about abscesses rather than actual infection. So often if you see an abscess, what we're actually looking for is an echogenic hole. You know, particularly you'd see it up here along where we call it the skirt of the aortic valve, you know, the structure of the aortic, bioprosthetic aortic valve. Often we're looking for a echogenic hole. And potentially we're seeing one up in the top up here. This is not it. This is an ordinary pericardial recess that we often see on toe, particularly when we're coming in here at sort of the 102 degrees. You can see, you've got to be careful that you're not calling something that's not an abscess. And that's just sort of knowing anatomy and doing a bit of toe. But honestly, you'd see this, particularly a sort of hole that's sitting up here, just a black echolucent hole that's sitting up at the top. With this kind of structure, you'd start worrying about it. So I think that's the way we're starting to look for abscesses. Nice. So maybe just in summary of what you're saying, remember, so we said that if you saw a lesion like this irregular, heterogeneous, echogenic lesion with independent motion, suggestive infective endocarditis, we think about other valves being affected in 30% of the time. We need to look for complications such as valvular abnormalities, and that's both regurgitation and stenosis. In a bioprosthetic valve, we talk about dehiscence and paravalvular leaks, and we talk about abscess formation, particularly in the aortic root, because that's at the very sort of center of the center of the heart. Sure.
When you measure the vegetation, is there a particular view or a particular dimension that's standardized, or you just pick the one that's the worst?
I picked the one that's the worst. And what numbers start scaring you? Oh, sorry, say that again.
What was the question?
Oh, I'm so sorry, you can hear. The question from Benny was, in which view do you measure the size of the mass? Is it standardized in any way, and how would you measure it? And I guess my answer to that is I measure it where it looks the worst. So I measured it in the other one at 8 by 9 centimeters. In this one, I'd pause it, try and find when it sort of looked the worst like that, and I pick it in two dimensions.
And that's the reason, I did off-axis image.
Very nice, and what a great comment. And did you guys hear that? So Vishal said that's the reason why he did off-axis imaging, which is really important for going to look for infective endocarditis, because sometimes it's not in that perfect 4-chamber view that you've got. Sometimes the valve doesn't sit there and it sits off to the side. So if you're in transthoracic, you've got to fan through the whole structure. If you're in toe, you've got to sort of rotate and use the omniplane all the way through it. You've got to use all angles possible to try and find your mass. And when you do, I measure where it looks the worst. I think if you've got a 3D echo probe, it might help to measure it up. But why are we, the measurement's obviously useful. We can talk about how it changes in size. What kind of numbers make you scared, Benny? Yeah. Yeah.
More than 1 centimeter, high chances of embolism.
Yeah, I think in the guidelines they talk about if it's greater than 1 centimeter in size, then that might be an indication to think about surgery, because we start talking about the high risk of embolization and severity of infection. In my experience, though, I've got to be honest, I've phoned up cardiothoracic surgeons and I've said I've got a lesion like this. I say I've got a lesion of 1 by 1.8. Will you think about surgery? And they'd say no. They'd say it's all dependent on valvular function as much as anything. Putting a patient who's sick with septic shock and strep viridans on bypass is no small thing. And particularly if you've got cerebral emboli, you've got emboli elsewhere, they're even less likely to do it. And it's all about valvular function. So certainly their ears would prick up, but unless you've got severe valvular abnormalities, in my experience, some of the cardiothoracic surgeons wouldn't operate just on the basis of the size of a lesion. It's all to do with valvular function. But I don't know if other clinicians have other opinions on that. Have you found the same?
Yeah, just I think, one point that if there are regions in 2 valves, then things are different.
Yeah, totally, absolutely. Yeah. Do you guys are working in cardiothoracic centers? Is it sort of the same with you when you've got infective endocarditis?
We are not in cardiothoracic center.
Oh, yeah, I have to transfer mine out as well. It's a shame. Lewis, you're in Durham, so you're in cardiothoracic center?
No.
No, excuse me. Okay, so I think
it just didn't happen.
Yeah, I think we're all struggling with that then. And I think sometimes it makes it even harder, right? I think for us in centres where we've got to transfer out, I work a little bit down in Canberra, and I've found that they seem to be much more open to the idea of operating on patients. And when I try to sort of send to our local referral centre, it seems to be harder, in my opinion. And maybe that's the importance of us learning how to do these echoes properly, so that we can have a bit of objective evidence to suggest that if we've got valvular dysfunction, it's not just on clinical grounds. Hopefully you don't pick up someone when they're in rip-roaring APO and trying to die. Maybe we can pick it up a bit earlier by doing some of this stuff. I think it's important. All right, how about maybe we'll just talk about if we're not doing a lot of toe, I think maybe I just want to show you one last thing then before we move on to another case. So I've always told you I've got 30% of our patients have impairment on both ventricles. 30% of our patients with infective endocarditis have another valve that's infected. I look at this valve and I can't see any horrible masses with independent motion. Then I show you this one. What do you think? What do you think about this kind of regurgitation and trying to say whether you think that there's a mass that's on the mitral valve or not? Lewis, why don't you have a go at this? What do you think? I know you're not doing a lot of toe, but what do you think about this regurgitation? And if I show you 2 views, let's put you that and this one. Oh, sorry. Give me your thoughts. So what would you say this was, normal or abnormal, and tell me why?
So I'm going to go with normal.
Yeah, me too.
It's not a large volume. It's there's 3 small jets there. They're all sort of central looking. There's the lack of large masses on the 2D There's no proximal flow acceleration, so it's not curving around something big and we're only catching the edge of it. That's not great.
And I guess for this one also we say there's not a huge amount of variance that we'd see that would be in there, or chaotic motion, and there's none of this eccentric nature, because often if you get a horrible mass that's eating away at a valve, you're going to get these weird jets that come off. These, I agree, I thought these looked like normal jets. I couldn't see any obvious 2D small echogenic masses with independent motion in there. So again, I said that I couldn't see any evidence on the mitral valve. That doesn't mean we should stop looking, but I completely agree. All right, unless there are any other questions, I might move on to another case, if that's okay.
Sam, just one question.
Yeah.
Is this, like, we have seen only one view? Is that enough to rule out?
I'm just trying to get it through. Absolutely. I think, as we were saying at the beginning, I think if you've got an abnormality, you've got to go using all angles that you possibly can to go and look at that mass. And that's how we're going to choose the biggest diameter to go and look at it, including off axis. So I've only showed you two just to try and get through at least a couple of cases. But if you see an abnormality in one plane, the rule is you've always got to go and look for it in another. And that's one of the ways we can make sure we're not dealing with an artifact. And of course, if you've got a biprosthetic aortic valve, it's possible to see artifacts. And if you see an artifact, you've got to be able to understand why it's there. You've got to be able to explain it from a physics point of view. So yeah, great comment. If you see an abnormality in one plane, you've got to back it up in another in as many views as you can. And that goes in line with, see the whole heart. And if you see an abnormality in a valve, you've then got to go and interrogate the valve to make sure it's functioning normally or not. And that means looking for stenosis and regurgitation. And if it's biprosthetic or mechanical valve, is it moving properly? Is it well seated? So yeah, nice comment. All right, let's have a go at another case, which I've also forgotten the number for. It had a J in it. That's all I remember. Hang on, I'm just gonna have a quick look. Can I slide back? HNC 69.
Oh, yeah.
Cool. All right, Lewis, this one's for you. So this would be a bog standard one that we get every day of the week in the ICU. All right. So this is the question that I'd kind of make up from this is that your registrar has come to see you saying that they've found a mass in the heart, and can you help them out with it? And in the meaning of time, we're going to go to the money shots. Why don't we just start off, before we get to this one, I'll start off with this one. So they didn't see it in this view, but tell me what you think about this view first of all. And this, I'm so sorry, this is a patient who is born in 1969, so that makes him about, say, 50 years old, and they're in ICU with hypotension after a recent non-STEMI.
Okay. It's a reasonable 4-chamber, could be centered better. Most of the right ventricle is not displayed, but the annulus is. The LV function appears to be reduced with mostly apical reduction.
And what walls of the heart are we looking at here?
So this is the septum and lateral.
Yeah, and you're not going to say septum and lateral in the exam, though. You're going to say, is it anteroseptal or infraseptal or anterolateral or infralateral?
Yeah, anteroseptal infralateral.
Or infraseptal, anterolateral. 50-50. I want to draw this for you. How can I draw and show it to you? I'm gonna do it by mine with my hands again. So I have to do exactly what you do. I have to stop and I have to think about it. And if you've got, I imagine a short axis view. Actually, let's do it on this. Perfect. So this is the view. When anyone asks me about chambers of the heart, I always think about the, if anyone asks me about walls, I just go straight to this view in my head. And I think about my short axis mid-papillary muscle view. And if I can draw a line, the ones that I know when I don't have to think about it too much is if I drew a line down from there to there, that is going through the anterior. If I do it like that, that goes through the anterior segment. Yeah. Oh, sorry, I'll stop moving around so fast. So I'm going to put my cursor there. That's the anterior segment that line's going through, and that's the inferior segment, right? And that's the two-chamber view. We know in the two-chamber view, we deal with the anterior and inferior sections. And I got to my two-chamber view from my four-chamber view by rotating anti-clockwise 60 degrees. So that means if I go back the other way and I went 60 degrees this way, I'd go across something like that. I haven't drawn it perfectly, have I? Let me try it. I'm going to do this one last time. Okay, so if I go like that for my two-chamber view, my four-chamber view would look something like that. All right? Because I moved, so my four-chamber view therefore must be my anterolateral and inferoseptal wall, because I went 60 degrees from my two-chamber over to my four-chamber. When I'm doing my apical views, if I go from my four-chamber to my two-chamber by doing 60 degrees, if I went another 60 degrees round, I would get that view there, which is going through my anteroseptal and inferolateral walls. So I remember going from 4, which is my inferolateral, it's my anterolateral inferoseptal, to my two-chamber, which is my anterior inferior, to go 60 degrees to my three-chamber, which is the same as my parasternal long axis. That's always the picture I've got in my head. So I start at my two-chamber, and then if I go four-chamber, I've just gone back 60 degrees, so that's the anterolateral inferoseptal. Cool?
Yep.
I hope that helps. There are probably other ways of doing it, but I do exactly what you do. I have to close my eyes and rock my head back, but you've got to make sure you get the right answer. Nice. So nice. So you picked up everything. So here we go. If we're looking at our inferoseptal and anterolateral walls of our four-chamber, we can see that we're moving nicely here, but right up at the top there where my cursor is, we've got what's known as a hinge point. And that's, we can see that there's thickening, and normal thickening is greater than 50%. And at the top up here, at the apex, we can see that there's nothing moving at all. And what your registrar called you is because they went there like the good doctor that you taught them to be, they'd gone to their two-chamber view and they'd picked up something that looks like this. And I don't know how well it comes up from your end.
Okay, so the concern is in that essentially akinetic part that there's a mural thrombus.
Fantastic. And you can often, I think the first port of call when you start to see an apical mass that you think might be a thrombus is, have you got akinesis associated? Because you don't get it unless you've got some form of abnormal flow there, and you've got to have akinesis to have a clot in the top of the heart. So what would you say? What do you reckon the chances that this is a thrombus? Because that's what your registrar was concerned about, a thrombus sitting at the top of the heart.
It's not completely akinetic underneath it. I'm just looking closer now. It's not completely akinetic. It's not akinetic at the edges. And it appears to be part of a reverberation series with the pericardium at the top. And
really nice. So that if you went down from a sort of layer of fat down to the skin, there's almost like a uniform distance. So we can start to say that maybe we've got a physical explanation for why it happens in terms of the physics. Excellent. So how else do you exclude it being a thrombus?
Another view.
Nice.
And a color Doppler from this view.
Very nice. And how does that help?
Yeah, so it looks like there's flow appropriately on both halves of the apparent mass. So
Any other ways of doing it? If you're mentioning all the right things, so can you explain it? Can you see it in other views? Does the color go over the top of it? Anything else?
Pulsed wave inside it, looking for velocity.
Okay, looking for flow. Yeah, I think we've got better ones. Yeah, nice. We're going to come to contrast at the very end. Beautiful. I'd also say changing the depth and going off-axis imaging. Off-axis imaging is a really important one for me. And that's where we're starting to do that here. We're trying to look off-axis to see if we can still see it in other areas. And then as Vishal just said, if in doubt, go and have a look for contrast. And I thought I had some contrast pictures at the bottom here. Maybe. No, I'm so sorry, I don't have them. But yeah, echo contrast is another way that we can inject it in, and the echo contrast lights up the inside of the heart, and we get to say with as much certainty as possible whether that is an abnormality or not. Beautiful. Guys, I'm sorry, I've rabbited on for long enough. We've gone on for a while there. I hope those couple of cases were useful. Just to summarize quickly what we were talking about in there. So masses, I guess, are super common in the critically ill because often we're hypercoagulable and there's increased risk of infections in the critically ill populations. If you see a mass, if we're talking about masses in general, let's remember that artifacts and normal variants and iatrogenic material are probably the most commonly seen masses in the heart. If it's pathology that we're looking at, thrombus is the most common, followed by infective endocarditis. For thrombus, if you're seeing thrombus, it's going to be in a low flow state, particularly for left ventricle thrombi. There's going to be in an area of akinesis at the top of the ventricle. You don't often get them if you've got normal thickening walls. If it's infective endocarditis, you've got to have a good story for it, and particularly positive blood cultures and signs of infection and all the peripheral stigmata of that. Neoplasms or cancers are uncommon, but metastatic is much more common than primary. The most common metastatic are the ones that are in two organs, so where you've got two organs of it, such as the lungs, the breast, the kidneys, and primary cancers. The most common are myxomas and papillary fibroelastomas, and I'll put a paper in the DDU Dropbox. Don't forget to say that you've got to go and look at toe if you can, because toe is much better at looking at masses than transthoracic. Okay, are there any other comments or thoughts or questions from anyone? You good? All right, well, thank you very much for joining us, guys. I hope that was useful.
Awesome.
Thanks.
Pleasure. Nice to